The testosterone being low, of course, is a natural part of aging. Just like women's menopause, men go through the same thing. So not all low levels are pathologic states. But when the low testosterone level cause symptoms, then it's time to talk about treatment. So just like treating anything else, there is a parameter, there's a matrix, there's a number or imaging study just like cancer, and there's another thing is symptom. And over the past several decades, the discussion about estrogen replacement for women has reached pretty concrete conclusions. We know when to supplement and when not to supplement in the risk and benefit ratio. But men's testosterone replacement is still it's an ongoing research process. So far, the data that you have heard of from the news is all so far retrospective study. That means reviewing the medical records instead of prospective randomized controlled trials. Randomized controlled trials are much more solid evidence in terms of medical science in supporting a theory. However, we still can get a lot of insights from reviewing chart records. And I would like to go over two of the most prominent research data that are claiming cardiovascular risk associated with replacement of testosterone. And using those two examples to talk about how to read about medical journals. Of course, I'm not going to give a complete talk of statistics, but I remember my professor told me that doctor in Latin means teaching, not healer, not just healer. So I would like to use moments of teaching incorporated into my daily clinical work, as well as teaching communities and medical students and medical residents. The high testosterone levels, however, intrinsic testosterone level, that's what I'm saying, the endogenous, the testosterone that your body produces, is associated with protective mechanism of cardiovascular system. That means when you have a higher normal testosterone level, the risk of heart attack and stroke is lower than the people who have low level of testosterone. I'm talking about endogenous, the hormone that you produce. And so far, there's no clear evidence of increased heart attack and stroke being associated with testosterone replacement therapy. And the problem with the advertisement for testosterone treatment is that, of course, it's common for pharmaceutical companies to list a lot of symptoms to alert you to talk with your doctor about the possible need for certain medications. But the problem is the symptoms are so general. The lack of interest in a lot of hobbies, the lack of concentration, the fatigue, the sleep disturbance, the reduced sexual desire, libido reduction, impotence, all of that are too general. And that means a lot of people would start to think of them as a patient even before going to see a doctor. And when the news of the treatment being so risky come out, people will start to think that even if I have very clear symptoms of certain disease, I'm not going to talk about it because I don't want to get killed in the process of being talked into a treatment that I know is risky. So anywhere when there's an action, there's reaction too. When there's so much advertisement, so much commercial actions there. There's always a reaction that there are people who actively search for the risk of associating with the popular product, and which is good. And when there is some data showing risk, news often would play it up very much because as a consumer protection, they want to counteract the previous perception of the wonderful thing that testosterone can do. They want to fill the gap of the danger of testosterone replacement. So news has its role too. But as a physician, I want to, from medical science standpoint, to give you the pros and cons. There are many agents of testosterone replacement. I'm not going to go through the medications itself or the doses because I'm not a primary care physician and I'm not a urologist. Just like a lot of risk factors are associated with cardiovascular disease, and I talk about these risk factors doesn't mean that I directly treat them, such as diabetes. I don't run a diabetic clinic and I don't have a weight loss clinic, but I know those are strong risk factors for heart attack and stroke. So I want to talk about the risk of low testosterone. And the testosterone replacement, there are multiple potential risks if the level is too high. And this is just a joke, that if it gets, this is a cheap joke, I think. I'm going to skip it. You can see the upper panel that the high blood pressure, high glucose, high lipid, the association with low testosterone is two ways. That means when you have very low testosterone, you tend to gain weight. And that kind of abdominal weight gain increase blood pressure, increase glucose, and increase lipid. On the other hand, when you have more abdominal fat, the fat in the abdomen is not just a passive deposition of fat, but it's an active endocrine organ. I call abdominal fat as endocrine organ because the fat can secrete a lot of endokines that increase the thickness of the blood. That means increase the blood clotting ability of the blood, and induce inflammation of the endothelium, causing the inner lining of the artery not being smooth, and that create a lot of plaque buildup. So the fat in the abdomen region, the central obesity, tend to associate with higher risk of heart attack and stroke, not just because people have more fat, heavier, tend to have high number of blood pressure, lipid, and glucose. When those are treated or under control by medication treating all three illnesses, the fat itself still secrete a lot of endocrine factors, the molecules that induce the thrombosis or blood clotting in the blood vessel and causing damage of the arteries itself, independent of the number of the blood pressure, glucose, and lipid. And the lower the testosterone, the heavier a person, the lower the testosterone. And when you actively lose weight, after 6 months, when you lost enough weight, testosterone level increases, even without taking testosterone medication. So losing the abdominal fat, losing weight itself already increased testosterone. And of course, it's not fair for me to tell a morbidly obese man who clearly have very severely reduced testosterone and say that you just go to lose 30 pounds and come back, we'll check your level again. In those cases, I may need to replace their testosterone if the level is really low, so that they will have better energy, a better metabolism, easier to build their muscle, and just at least have some strength to do the daily exercise. And after they lose 30 pounds, I check the level is good, then we may lower the replacement dose and slowly taper off the medication if possible. So From this, you can see even just weight loss itself increase the testosterone level so much. And the association, strong association of low testosterone and heart attack, stroke. The lower the testosterone level, the higher the risk of heart attack and stroke. So it's not just a sex hormone. It's not just a hormone that makes you feel good, but also a hormone that's essential for your heart and artery health. So these are the two studies that have been widely reported over the past 6 months, at least on the news. I don't watch TV for many years, but at least from my patients, they mentioned that the risk, and they heard from the lawyer, and they always bring up this topic, and I read journals all the time, and I would start discussion with them. And then sometimes I go home and search for the videos of those lawyers' commercials, and I realized how much worry my patients must have. And I read the details of the studies. I want to at least use these two examples to discuss the shortcomings of these two conclusions, these two studies. All studies have shortcomings. There's no perfect research. But the peer-reviewed journal for physicians to read are providing us additional information so that we can build on the previously formed structure of our information. It's not meant to be taken out of context to use one number to draw a conclusion. And our job is to incorporate all of those information and have a discussion with patients and family. And whereas news for non-medical people, they tend to get one number and report it, and oftentimes without background, it's hard to differentiate which one is the most pertinent. Initially, this most important or most famous, not most important, but famous article was published in Journal of American Medical Association in November 2013, 8 months ago. And it says the absolute risk of testosterone replacement increased the risk of heart attack and stroke by 29%. And there are several critiques, there are several shortcomings. One is that in the group that's treated with testosterone, first of all, this is a chart review of a patient's chart from VA system. And there are testosterone levels listed of the group of patients who eventually get testosterone treatment, and the baseline testosterone level is lower than the non-treatment group. And as I already talked about, the risk of low testosterone associated with high risk of heart attack and stroke. That means the group that gets treated with testosterone already have a baseline risk that is higher, baseline risk of heart attack and stroke, higher than the non-treatment group. So you're not comparing apple to apples. To me, that is already one shortcoming. Second is that when they identify the 8,000 subjects from the chart review, they identify those 8,000 patients with a coronary angiogram performed within 530 days. That means they have a cardiac cath 1.5 years before they started to get treatment with testosterone. And the patients who suffer heart attack and stroke are, before they get treated, are not counted as the events in the non-treatment group. In my opinion, those should be counted as non-treatment group. If those patients are counted in the no testosterone treatment group, the result will be drastically different. So because they teased out those patients, those 1,000 patients who already suffer heart attack or stroke before they get the testosterone treatment, as opposed to group them into non-testosterone group, these data already heavily skewed. And the third is that when they report the final result, they reported a statistic, they reported a number that's after the multiple calculations, a derived number instead of a raw data. If you look at the raw data, the patients who have gone through testosterone treatment actually have a lower heart attack, stroke, and death compared to the patients without testosterone treatment. So the further you are from the raw data, the more careful you need to be in the numbers reported. So I'm just using this as example to talk about how to read studies, to see if their baseline properties are matched, to see how in the process they categorize people with event into what group, and to see how far the result is from the raw data. So after the doctors provided a lot of input, JAMA wrote another, revised the conclusion. And that point out the statistic method that's being used and point out the initial report was not the raw data report. But of course, these are not reported by the news to the general public. Another report, another data also show that risk of testosterone treatment include increased chance of heart attack and stroke. However, if you look at the details of the number, is that if you treat 100 men with low testosterone with replacement, if you treat them for 10 years, one of them would have heart attack and stroke. And that means if you think of the flip side, the 99 of them who benefited for 10 years from testosterone treatment are not being, of course, when you report the risk of something, you don't report the people who are helped, which is correct. But you look at the 1,000 person years treated to have one problem, one patient who have trouble. That also tells you the level of risk. So these are the two trials, or not trials, research I would like to just talk about here to let you know all numbers have a lot of background noise there for you to tease out. And therefore, discussion with your physicians and the treatment team are the most important part before you draw a conclusion. So when we look at, whereas the low level of testosterone association with heart attack, death, and stroke is very strong. Even though so far there's no evidence of treating low testosterone would lead to better cardiovascular health. That means you cannot replace testosterone as a way to prevent heart attack or stroke, which is different from lipid, blood pressure, and glucose. If you treat blood pressure, lower the lipid, you reduce the heart attack or stroke and death associated with heart attack or stroke. The same thing cannot be said to testosterone replacement, and that needs to have further study to elucidate. So what I want to say is that with all the decisions in medicine, everything is just like in life, is associated with potential risk. But when you want to talk about what you can gain from getting something, you can, at least to me, I use this house effect. When you have a house, you want to stay in the house, there's a floor, there's a ceiling. When you have very, very low testosterone, you feel bad, you're in the basement. And when you have the replacement, your point is our work together. Your discussion with your physician is to try to monitor the level so that you stay in the house instead of going up to the attic. And that is my quick